We're going to go ahead and get started this evening. Thanks everybody for joining us. Hopefully this will be an enlightening evening for everyone. And I'm hoping my slides will go. Okay, so as you all know, this is part of the Florida Foot and Ankle Fellowship Society. This was an initiative that was born through the Florida Pediatric Medical Association and the Florida Pediatric Medical Society. And this was something that was kind of near and dear to our hearts. We as fellowship directors in the state of Florida, came together and just kind of felt like there was an opportunity to join together in a way that would lead to the promotion and coordination and advancement of fellowship training. And we formed the Florida Fellowship Foot and Ankle Society. And our goals are to kind of promote fellowship training within the profession, but also kind of pave the way for tomorrow's leaders. We are ran through the Florida Pediatric Medical Society, which is the non-for-profit arm of the FPMA. And they have been very gracious in helping us get organized and giving us a non-for-profit status. And some of their goals are listed here, but we do have Dr. Terrence McDonald on, and I was going to have him say a few words about the FPMS. So Terrence, if you would hop on and kind of chime in and kind of tell us about what you guys do.
Sure. Thanks, Adam. I'm not going to turn my video on. I'm not dressed nearly as well as Dr. Belis is, so I wasn't prepared to have a suit and tie on, which I rarely am anyway. But
you don't know what I'm wearing underneath this.
This is true, and I don't want to. But you know, the society has been active in the FPMA for, gosh, probably 20 years. And for most of that, lay dormant with not much activity going on. And really in the last 10 or so years has become more and more active in providing scholarships to podiatry students, especially at Barry University, and also working with various charities such as the Special Olympics and ADA and other state organizations to really promote podiatry to the Florida public. But Adam and Andrew came to the society several years ago and had pitched this idea of having this fellowship society, and it really marked in line with what we're doing as far as education and trying to promote education of podiatrists and also education of future leaders, just like Adam says so eloquently. So really, really happy and proud of what these guys have done and what they've done in the name of the society. I love to take credit for everything, so keep working it, and I'll keep taking credit for it. But we're the board of the society is excited about where this is going, and looking forward to seeing more and more of the fellows come through and seeing them become our future leaders, which is really what this is about and what the society is about as well. So I'll leave it there and let you guys move on. Thanks, Adam.
Oh, you're welcome. And that's exactly what the society is about. So our mission is to encourage the growth and fellowship training opportunities in the state of Florida. But more importantly, we're planting the seeds for tomorrow's educators, researchers. And I think that those are all going to come through the fellowship ranks, in Florida and across the country. And this is our little webinar series. So hopefully if this is your first meeting, this will be exciting. And if it's your second or third meeting, you've already seen this. But this is a Roundtable of Excellent webinar series. This is a series that was created basically to have monthly engagements with residents from across the country and potential fellows, people who are in the industry. We have all different types of people logging into these all over the country. So we're really thankful for that. These are the participating programs in the webinar series. We have 8 programs from the state of Florida, and we have 3 programs from across the country that are going to be contributing at some point. So each month we'll have a new topic Our goals are, basically education, exposure, promotion, and sponsorship. So education comes in the form of the webinar series. With the exposure, we're giving each fellowship site kind of a virtual visit opportunity. So potential fellows or residents from across the country can kind of check out what each fellowship's doing and hear from the current director, some attendings in the program, and the fellows. Of course, we're trying to promote educational training and fellowship training both locally and nationally within the industry. And finally, this wouldn't be possible without sponsors. And what you'll find with each of these sessions is we'll always have an opening by one of our sponsors, and that's really, really important because that's what paves the way for some of the exciting opportunities for our fellows. And if you were part of our first meeting, we talked about missionary medicine and the opportunity for fellows to go and participate in mission programs. And some of the funding that we're raising from this series will help pave the way for those opportunities. So this is a year-long series. It's typically the last Thursday of every month, although with the holidays, we do have some that are going to move around a little bit. But if you go to the FPMA website, there's a section for the Florida Foot and Ankle Fellowship Society, and the Roundtable of Excellence webinar series master calendar is posted there. And most importantly, help us spread the word about this. It's free for everyone to attend. It doesn't have to be people involved in fellowship. If it's just doctors in the community that are wanting to get educated, this series is really for everyone. So next month, we're going to be delving into the current status of total ankle replacement. That's going to be by Westside Regional Medical Center and Dr. Windrum's program. And this is a great looking panel of doctors that are going to be speaking on kind of an update in current concepts in total ankle. So that, again, is not going to be at the end of November because of the holiday. So that meeting is just a few weeks away on November 18th. So 7 p.m., it's a Thursday, and that should be a great topic. But without further ado, we're going to introduce tonight's topic, which is Adventures in Arthroscopy, Tips, Tricks, and Pearls. And a great thank you goes out to Dr. Belis and his current fellow, Julio Perez, and his past fellow and current partner, Dr. Gregory Foote. Sorry about the striker on the bottom. That's not supposed to be there, but I wanted to thank OrthoMax. OrthoMax has been one of the corporate sponsors for us. They have a strong presence in the state of Florida, and they do represent a lot of different products. So they're actually a distributorship and more than likely have somebody in your area that can help you with the product. So at this point, I'm going to turn it over to Jeff Golden. He's our corporate sponsor from OrthoMax. So Jeff, thank you so much for your sponsorship and support of this series.
Thank you, Dr. Perler. I appreciate the opportunity to get to know you guys. I know a lot of the surgeons on the call and on your panel and your fellowship directors. A little bit of history about us, the distributorship. Original distributorship was formed in 1997. I kind of kid that we were in foot and ankle before foot and ankle became cool and mainstream with big ortho. We separated our two business units in 2011. That's when OrthoMax was founded, and we our sweet spot is extremities, deformity correction, and we specialize in this disruptive technologies that are new and innovative. And we've had a 20-something year history of bringing these new technologies to the marketplace. Next slide. This is our geographical footprint. We cover most of the state of Florida. We don't include what we call Lower Alabama, the Panhandle, but everything else. We've got 17 full-time sales reps that cover most of the geography for us. Next slide. These are some of the main foot and ankle product lines that we carry. Artelon, Crossroads, MedArtis, Voluminous, and Biocomposites are primarily what we focus on in the foot and ankle space. Next slide. I just wanted to cover a little brief introduction as to some of the key products with each product. Crossroads, I know a lot of you guys either are very familiar with our Dynabunion Lapidus system, or our mini bunion distal bunion correction system that one of the fellowship directors was instrumental in bringing to market. Next slide. This is the Dynabunion. It's a fully instrumented Lapidus system. Really makes this a hands-free reproducible system in the hands of just about anybody. And one of the key features, the fourth dimension, as we call it at Crossroads, is it gives compression through the osteotomy site. Next slide, please. That compression comes through the insertion of a nitinol staple that is implanted through the plate. So as we get some bone remodeling or resorption, this nitinol staple will compress at the osteotomy site, fusion site. Okay, next slide, please. The other product, as we try and own the first ray, is Dr. Lamb's Mini Bunion 3D, which with the new Viking instrumentation, it allows us to control the capital fragment and give that coronal plane correction that you guys are seeking in these new bunion procedures. Next slide. It's a brief overview of what the capital fragment control guide, the Viking ship, as we call it, looks like. And what that does is it makes your osteotomy and your correction hands-free as you go to your definitive implants and fixation methods. Next slide. That's what the implant looks like. There's a non-locking screw and a locking screw goes into the capital fragment. Non-locking screw is used to get some compression along your fusion site. Next slide. We also have had the pleasure of working with MedArtis for 15 years now, since MedArtis came into the US. Brief history of MedArtis is 35, 40 years ago, MedArtis was the metallurgist for what is now Synthes Global. They made all the plates. Long history of working with metals. If you ever had the opportunity to put one of these plates in your hand, you can tell that there's something to this Swiss-made technology. These plates are very elegant. Next slide, please. This is a brief overview of what the foot and ankle product offering is from MedArtis. Just released a pretty comprehensive ankle trauma set, in addition to corrective osteotomy plates, a wider range of screws, headed, headless, compression, or non-compressive headless screws as well. Next slide, please. This is a brief overview of the new ankle plates. A couple unique features in these ankle plates. There's a Wagstaff hole in some of these plates. Just released this year. We've been had the luxury of being on the early release team here in the state of Florida, and it's been fantastic. So next slide, please. We also carry Artelon. I don't know if I know some of you are familiar with Artelon. Next slide, please. Artelon is got those origins back in sports medicine. Lars Peterson, 20-something years ago in the 80s, was trying to figure out a substitute for artificial ACL ligaments. And he worked with the folks at Artelon to come up with this material that he had great results with as a supplement to failed ACL reconstruction. Next slide, please. There's a couple key features with Artelon. It really, the key is it's a synthetic fiber that resists necrosis, and it's kind of like a lycra material. It stretches. It's not a static fixation device like some of the other devices on the market. So you immediately it incorporates into the tendons, and it does not restrict the tendons during the healing process. Next slide, please. This just briefly goes over what the matrix is. Like I said, it's an implantable lycra. Love to get it in your hands so you can feel it, and that's really where the rubber hits the road. Next slide, please. brief overview of some of the procedures that we're utilizing the material in. A lot of lateral ankle stabilizations, getting some good results with reinforcing the collaterals and total ankle reconstruction as well. Next slide, please. Illuminos is a brand new company, new technology. Next slide, please. It's a polymer that you put in through a minimally invasive incision, and it's a monomer. And once you put it in, it's in a balloon. You fill up this balloon with this monomer, and when you're happy with what your reduction is, you hit it with an ultraviolet light. It solidifies. It turns the monomer into a polymer to give you stable ultimate fixation. Next slide, please. This is kind of what it looks like, not in a fibula, but in a humerus. And you can see it's got these tantalum markers through it, so you can see where the outskirts of the implant is. Next slide, please. That's pretty much all I got, Dr. Perler. That's a quick, brief overview. I hope I didn't take up too much of your time. I really appreciate the opportunity to present and look forward to supporting the program in the future.
Jeff, thank you so much. We appreciate your sponsorship and support of the fellowship program, and of course, indirectly all the fellows. So on behalf of all the directors, thank you for your support. So I think at this time we can go ahead and get started with our main program. And I will hand it over to Dr. Belis and his crew.
Okay. Hello. Oh, hi. Hi, everybody. Well, thank you, Jeff. Thank you so much for your sponsorship and participation with this series. I think this is really good for the fellows and the training of the young people across the state of Florida. So I need to figure out how to allow me to share my screen. There we go. So we're going to be speaking to you today from rainy, thunderstormy Fort Myers, Florida. And basically we're going to be, let's see where we are here. There we go. Can you all see my screen? Yeah. Okay, good. So today we're going to be speaking about something we do a lot at our program here. We do a lot of ankle arthroscopy, and Dr. Daniel Perez will be speaking first, and then Dr. Gregory Foote, and then myself, and we'll have a little discussion. And I think you guys are going to pick up on a lot of cool tricks. We'll go through a little bit about our program, and I'll let these guys take over. So I'm going to stop my video sharing, but I will let each of these docs speak. Okay, hold on one second. Here we go. There we go.
Hi, everybody. Like Dr. Bella said, my name is Danny Perez. Some of you may know me by a couple of other names, but it's good to be here with you. And we'll be getting to talk a little bit about our tips, tricks, and pearls, and our adventures into ankle arthroscopy. So here we will begin and embark on our adventure through ankle arthroscopy. Here you can see Dr. Belis, myself, and Dr. Foote flying, skydiving on our adventure. Just to give a little background information about our program, and before I actually get started, I do want to thank Jeff for helping support this program and opportunity for us to give these lectures and be a part of this society. I think it not only benefits us as fellows, but it also helps, like Dr. Bella said and Dr. Perler alluded to, other doctors in the facility, that are tuning in and wanting to just see what kind of advances we're all doing and what interesting topics we have to talk about. So thank you to Jeff, and thank you to all our other sponsors as well. So with that said, a little background about our program. Here at the Orthopedic Center of Florida and this fellowship in particular, we're part of a multi-specialty orthopedic practice. We have an emphasis on sports medicine, arthroscopy, and now recently we've definitely picked up a lot of minimally invasive surgery techniques and forefoot reconstruction. We're a very well-rounded program, but those are definitely some of the highest volume of surgeries we do. Definitely doing a lot of total ankle arthroplasties. On average, I think the year before me, Dr. Foote was nearing 500 cases, and I'm on pace to be around there, if not a little more. So a very high volume for a year program. In addition to the opportunity to have my own designated clinic run a couple times a week. I'm on call at all the hospitals, and I am able to see all these consults and treat and operate on these patients independently. The clinic is also really well-rounded in that it provides the opportunity to not only work up surgical consults, but we also get to see a lot of workman's comp. And I definitely am getting well educated on my billing and coding. So that's been a really nice, part of this program. With that said, let's get on to the main event. So our hope is that by the end of our lecture, we would have imparted some of our tips, tricks, and pearls from each of our own experiences in ankle arthroscopy. Ankle arthroscopy has really risen in its popularity over the past 50 years. I won't bore you with all the history and mumbo jumbo, but over recent years, we as surgeons, as well as technology, continue to evolve and improve. And this evolve has allowed for expanded applications of ankle arthroscopy. And every day we're pushing the boundaries more and more. And even with its increased popularity and increase in use, many studies report its low complication rates, which makes it an invaluable tool for the foot and ankle surgeon. So although the place for diagnostic arthroscopy is limited, direct visualization of the ankle joint gives us the opportunity to confirm pathology that may have otherwise been missed on other exams like MRI or CT. For example, some studies report that diagnostic arthroscopy has the highest sensitivity and specificity when you do compare them to CT and MRI. Like I said, it's an excellent tool for diagnostics. However, very rarely do we simply use it for diagnostics. I would say almost 100% of the time we're using it as a therapeutic tool to resolve any unresolved ankle pain. Some of the most common pathologies that we approach with ankle arthroscopy are synovitis, ankle impingement, ankle instability, and post-traumatic symptoms, just to name a few. Ankle pathology can present in a variety of ways, but a few common themes that we've noticed, and I think most would agree, are direct ankle pain when these patients present to the office. A lot of times these patients have history of gout or other arthritides. Any complex history of ankle sprains or trauma is definitely a red flag for intra-articular pathologies, and periarticular disease can present in a multitude of ways. And with that said, even with a thorough history and physical, MRI really is the gold standard in assessing most intra-articular structural damage. Although that history and physical can help point you in the right direction. CT scans can easily identify osteochondral lesions of the talus, while MRI can also be a valuable tool in evaluating subchondral edema and other periarticular pathologies. So we can have a good idea of what's going on by performing some provocative tests, such as the anterior drawer sign here. We can see significant instability, at minimum 2+ drawer sign. But other tests such as the Malloy's test is very sensitive for ankle pain. And just for reference, in '96, a study published by Van Eyck reported that anterior drawer test is the most important test in detection of acute and chronic ankle instability. And again, this video, I think it really highlights, what you can anticipate to see on these physical exams. So this, I think, is a fantastic diagram and slide to talk about. I think good communication with the operative team is critical to maintain efficiency of ankle arthroscopy and in general, most procedures, but particularly ankle arthroscopy. This diagram is a sort of schematic that we use for our room layout. From the time we arrived to the operating room, Dr. Belis and I, and I'm sure Dr. Foote would agree, we are all in constant communication with the operating room team. We make sure that everything from the room setup to the instrumentation and the hardware is all ready to go, even before we've arrived to the operating room. Typically, we request general anesthesia with paralysis, and this allows us to manipulate the leg and ankle without any kind of resistance from the patient. As an alternative, you can request a regional nerve block that can offer similar benefits regarding ankle distraction and manipulation. Again, this is another critical slide for this PowerPoint. I think this should really highlight one of the most important take-home messages from our pearls. in ankle arthroscopy. To me, patient positioning is a game changer. Patient positioning can really make or break your case. In this diagram, we see how our thigh holder is positioning the leg. And this helps maintain the thigh at a relative 45-degree orientation to the hip and table. Then, further distally, we can see that the leg is maintained at about a 90-degree relation to the knee. Having an ipsilateral hip bump also allows for additional rotation of the lower limb so that we can have better alignment during our non-invasive ankle joint distraction. This image reinforces that concept of the positions of the thigh at a 45-degree angle and the leg at a 90-degree angle. In our practice, we prefer the paint roller style of a thigh holder in the popliteal fossa. However, a vertical thigh holder can work just fine. I also wanted to point out the positioning of where the thigh holder is being clamped. And if you notice, it's clamped just proximal to the leg portion of the bed. In other words, when the foot of the bed is lowered, the thigh holder will maintain its position. And not really well visualized here is a thigh and leg protector on the contralateral limb, which is obviously secured with tape. And equally important is the placement of that tape that you use to secure the contralateral leg. You want to make sure that that tape is placed proximal enough on the foot of the bed so that it doesn't interfere with the placement of the clamp that will be used later for the non-invasive ankle joint distraction. And you can see these highlighted by the arrows on my slide here. So ultimately, the first decision that the surgeon must decide when choosing an ankle arthroscope is, it's such an important concept. Having the right instrumentation, multiple camera options and shaver size options are available. But in our practice, we most commonly use either a 2.7 or a 2.9 ankle arthroscope at a 30-degree viewing angle. And what the 30-degree angle really is beneficial in is that it provides a wider field of view in relation to the other viewing angles. It allows us to see quite a bit more of the ankle than the other ones would provide. I think, I'm sorry, to go back to the previous slide, I think it's also really important to emphasize that if you do implement ankle arthroscopy in your own practice, I think it's a worthwhile investment to try to get some top quality instrumentation and equipment. I feel spoiled, being at some of the facilities that we work at because we get to use, high quality, 4K definition cameras and monitors. And we have a really good setup in most of the facilities we work at. So it's really nice to get to work with these sort of instruments. So just basic overview of some of the most common instruments that you'll come across, not to bore you too much, but obviously shavers are typically used for soft tissue debridement, articular debridement, and very minimal bony resection. For the larger bony resections and larger osteophytes, you'd want to use a burr, which burr can also be helpful. And 4.0 millimeter burr can help you in other larger procedures and larger osteophyte resection, or even in preparation of the ankle joint for arthroscopic fusion or ligament repair. Arthroscopic graspers are pretty self-explanatory. They remove loose bodies, material or tissue manipulation within the ankle joint. I think probing of the joint initially, especially when performing your joint survey, is very important. You can manipulate loose bodies, examine the articular surface, and even determine the depth and measurements of osteochondral lesions of the talus or tibia. And you can identify the extent of delamination of the cartilage. It's so critical because at this point, this is our opportunity to evaluate the joint for any kind of osteochondral injuries or intra-articular pathology that may have been missed on that MRI that you probably ordered before going to surgery. So don't be afraid to palpate the joint surface. When you feel it, it should really feel firm, and there should not be any sort of bounce or elasticity to the articular surface. If there is anything of that kind of, if there's any findings of that nature, you may want to be a little more aggressive in evaluating that region, and it may need some further debridement at that point, where you can see that kind of on the lower left image, we noticed that, delamination of the articular surface. And then finally on the bottom right, we can see that probe that's, identified that lesion and the extent of it. Osteotomes very generally obviously can be used for resection of larger osteophytes, ostrigonum syndrome, larger osteophytes on the tibiotalar surface. RFA or coblation ones are really useful for shrinkage of synovitis or tissue within the ankle joint. We often use the RFA one to debride the anterior distal fibula to prepare for the insertion of bone anchors, which you probably see later in this presentation. You can also use it, it's essentially the bovie of the ankle joint, so you want to use it for hemostasis and preventing any hemarthrosis of the ankle joint postoperatively. Arthroscopic curettes, again, can be used to resect bony defects, cysts, and denude the articular surface in preparation for fusion. I know we all know our basic anatomy, but some of these structures are not always easily visualized, and what we can call, or not really easily well visualized on some of the heavier individuals we may operate on. But if all else fails and you're having a difficult time identifying some of these important neurovascular structures, just palpate for the larger landmarks like the tibialis anterior tendon. And when you find it, just stay medial to it. Try to hug and air just slightly medial to it so you avoid that medial neurovascular bundle. And likewise, you can also go just lateral to the extensodigitoral longus tendon or peroneus tertius tendon and avoid that superficial peroneal nerve. Excuse me. So just like anterior access portals, when approaching the posterior ankle arthroscopy, it's best to try to maintain, air just, on the side of the Achilles tendon to avoid penetrating any of the important medial neurovascular structures or the sural nerve laterally. Also avoid, the peroneal tendons and posterior tibial tendon. So this is a great slide showing how we talked about earlier the clamping of the non-invasive joint distractor. We can see here how it's maintained at the foot of the bed and it's applied in a sterile manner.
We lost your audio there. Hey, Danny, we can't hear you.
Audio. Turn off your.
Okay, we're back on.
I lost connection.
Recording in progress.
1 second. Sorry about that.
The wonders of technology.
Can you hear now?
Yes.
Hello?
I think you're muted.
Yes, we can hear you.
Okay, good. Sorry about that.
Good. Okay, so back to this slide. Again, this slide just emphasizes what we were talking about a little earlier regarding the non-invasive ankle joint distractor. You can see how it's clamped at the foot of the bed, and we use a lot of ankle joint distraction, and I think we'll talk a little more about it throughout. I think it's ankle arthroscopy without ankle joint distraction proves to be much more difficult, and trying to treat any of the central or posterior lesions, while it sometimes can be done without ankle joint distraction, I think having it is definitely a critical tool in fully performing an appropriate ankle joint arthroscopy. And it can be safe. Most studies show that it can be safely applied for about an hour with about 30 pounds of pressure or 135 newtons. And one take-home point that I want to talk about is regarding sterility of the surgical field. If you do decide to use this non-invasive ankle joint distractor, when this is clamped to the draping on the side, it's best to just probably leave the clamp applied during the duration of the procedure, even if the non-invasive ankle joint distractor is removed and you're moving on to another portion of the procedure, just to protect the sterility of the surgical field. Again, the benefits of non-invasive ankle joint distraction is that it can provide, adequate visualization of not only the anterior joint capsule, but then the central and posterior joint capsule. And it allows us to manipulate the foot in a dorsiflex position to treat those anterior lesions, to quickly move into a distracted or slightly plantar flex position for treating those more central to posterior lesions. Here on the left image, you can see just how much distraction we can get once we, plantar flex the foot of the bed a little bit with the ankle joint distractor to treat those, central to posterior lesions. So at this point, I would like to turn it over to Dr. Foote, who can give you a couple more pearls on some more of our arthroscopic techniques. Thank you.
Thanks, Danny.
All right, everyone, I hope you can hear me. I'm Greg Foote. I'm the past fellow and now associate here at Orthopedic Center of Florida. I did my residency training at University of Florida in Jacksonville, where I was also exposed to a pretty fair amount of hind foot arthroscopy, as well as tendoscopy as well. So starting from the basics, I know it's pretty rudimentary here, but obtaining access to the joint can really be one of the most important parts of the case. I think it's absolutely worth touching on. So, and our Danny mentioned before, we use an 18 gauge spinal needle, and we come from the medial aspect of the joint first. Once you confirm your trajectory, the needle's then removed and 11 blade is used to make stab incision, just stab incision, large enough so you can get the trocar and the cannula in. I think it's something that not everyone realizes. You don't need these big monster incisions with a 15 blade, really just a nick on the skin with an 11 blade. Then you put a mosquito hemostat in across the front of the joint with the curve of the hemostat facing away from the cartilage, a single spread, and that allows you to kind of set your track. Once you have your track, you go back in and out the same spot every time. We also do use a pump with our distraction, and usually set that around 55. Sometimes you can up it a little bit if you need a little bit more insufflation of the joint or decreasing it. So again, the medial portal is established, and it's made just medial to the TA. I think it's pretty safe portion where you can go into the joint. Almost looks like you're given a regular ankle joint injection. You put the needle in. As soon as you find the free spot where the needle goes in, that's your point. Again, make your incision, and then enter your cannula and trocar followed by the camera. Once the camera's in, you actually use that 18 gauge needle on the lateral side of the joint, and you'll see just what we're seeing here. Where you can actually see the needle coming in the lateral portal. Now, this is important because this is going to allow you to know that your portal's in the right spot. So you can use that needle and move it as many times as you want before you make your incision. Once you make the incision on the lateral portal, you bought it. So you go ahead and remove it until you like where you're at. So modify this if you need to get to certain pathology, maybe a little bit lower if you want to get more towards the back of the joint or on the posterior aspect of the tibia. But you remove this needle on the lateral aspect to make your incision over here. Also, you can transilluminate the lateral portion of the joint, and you can kind of see through the skin if you have the nerve kind of in between where you're going. So as Dr. Perez mentioned before, that last extensor tendon will avoid the SPN nerve. Once we gain entry to the joint, then we can do our joint survey. So I'm sure we all know about this standard taught 21-point arthroscopic exam, but I think that a true 21-point exam really does not need to be performed in all these cases. It's more important for us to establish kind of a reproducible joint exam that works the best in your hands. Every time you're in there, you should be doing the same joint exam. This allows you to get maximum efficiency in your scopes and also reproducible results. So here we see kind of our basic modified 21-point exam. So we start medially, we go down the medial ankle gutter, across over the deltoid ligament to the back of the ankle joint, looking at the posterior or the transverse tib fib ligament, the posterior capsule, syndesmosis, the ITFL and the AITF, as well as the anterior portion of the ankle joint, and scouring the cartilage. And here we get to see a nice little medial defect as well. So I think this video shows us the importance of that ankle distraction to really gain access to all areas of the joint that we're trying to look at. So here we see another modified exam. This time it's a right ankle. Again, we do this in similar fashion. We're coming in from the medial side. And you can see here the manipulation of the light source is really our way of getting around inside the joint. So establish a horizon when you're in the joint. And that should remain the same at all times. So the tail should be on the bottom, tibia should be on the top. And an easy way to remember this is the buttons of the camera should face towards the ceiling, and that'll keep your orientation. Another tip here is when the light source is, where that light source is facing coming into the camera, will be where you're looking in the joint. So if you look at the picture here, that light source is facing straight up and anterior. You're going to be looking at the anterior capsule. That's a picture there. Soft tissue pathologies is likely going to be the first thing that you're going to see on your exams. Most often, this is going to involve gutter impingement, synovitis at the anterior portion of the capsule, low-lying AITF or hypertrophic tissue in the syndesmosis. But additionally, you may see some of this gouty tophi, which you can see in this video pretty well, which can also be mistaken as deposits from previous ankle joint injections. So the protrusion of the syndesmotic tissue is kind of depicted here. You can see the central aspect of the syndesmosis with tissue coming out both posteriorly and anteriorly. And on the right, we can see the lack of impingement once it's been appropriately reduced and cleared. So the debridement of the synovitis and soft tissue can be performed well with a mechanical shaver, as you see here, going after this nice inflammatory tissue at the back of the joint. You can see that the posterior and the anterior portion of the ligament remain intact, and really debride this down to appropriate level, and it's not going to violate the syndesmosis. Following this, we typically use one of those RFA or chelation wands and are able to shrink and cauterize that residual tissue to prevent it from coming back. Here's a study that we presented last year looking at the incidence of that pathological tissue and syndesmosis, as well as at the AITF. It's currently waiting publication, but specifically we looked at the presence of that syndesmotic impingement and low-lying AITF over a 5-year period in a total of 233 ankles. Really, syndesmotic overgrowth and inflammation routinely occurs following any ankle injury. So some of these patients present, they have continued pain as well as sometimes clicking and impingement in the joint. And as you can see here, this looks like some pretty angry synovitis with that typical crab meat appearance. So this is an obvious pain generator for these patients, and alone, I think it's an indication for ankle arthroscopy. So over our 233 ankles, we saw that this pathology was present in almost 70% or 2/3 of our cases that had symptomatic pathology. Now, this is pretty significant. You know, this is very common. It's more present than it's not, and we should be really treating this every time we see it inside the ankle bones. Again, we see it here in the posterior portion of the joint. And now, you know, routinely debriding this is not going to affect the stability of the syndesmosis. So your PITF ligament's still intact in the back. It's okay to kind of be aggressive and go after these. Now, after we appropriately reduce the tissue, the integrity of the syndesmosis should then be looked at. So the shaver's useful in order to kind of test the syndesmosis a bit. Now, you don't need to force this up into the tib-fib joint. I think you can easily force it if you wanted to, but if it is allowed to escape up into the syndesmotic recess, there's probably some instability that's present there. I'd say a good rule of thumb is if you can no longer see the teeth on the shaver, then the syndesmosis probably has some instability there. So I think you can see that pretty well here. You debride this area out, allowing for new healthy tissue on either end to approximate with each other. And again, see on the right here, this is a pretty unstable syndesmosis. And you should maybe consider some ancillary fixation in these types of cases. Another way to really examine the integrity of the syndesmosis is to test it with the shaver. So in this video, you can see this is definitely unstable. So this guy has got some pathology definitely resulting from that distal tib-fib joint. Manipulating with the shaver, I think, says it all. So when you are going to expect that this is going to happen, have some extra fixation in the room. Have them bring some dynamic fixation. You can always do a percutaneous, suture button or suture tape, even arthroscopically, and you can visualize your reduction through the arthroscope and then percutaneously insert the dynamic fixation across the tib-fib joint. So another main pain generator is the Facets ligament, or that kind of accessory low-lying portion of the AITF. It's a normal anatomic finding. It's present in up to 90% of the population, but really what happens is this becomes symptomatic in those people that continue to sprain their ankle. So after a few ankle sprains, you're going to start getting some pain anterolaterally. You can even get a little bit of kind of polishing of the anterior lateral shoulder, the talus. And this ligament starts to cause some impingement as well as a pain generator for this patient. So through the arthroscope, this is what you're going to look at. I think the illustration on the left really shows this pretty well. So the Facets ligament, it's portion of the AITF. It's not the AITF. So we identify it here, but it doesn't look unhealthy, but it's also not necessary. So again, this video will show you kind of what this looks like. And although it doesn't appear inflamed, you can tell this is hanging pretty low, and it's going to catch and cause some impingement, especially when they have some other ankle instability going on. So our study in those routine ankle scopes and those patients that had pain, 233 of them, almost 40% of them had this low-lying AITF ligament. Now, it's an accessory ligament. It's not going to affect the function or the stability of the syndesmosis. So when you see this, it should probably be taken out as well. So once you identify the ligament, you can try to eat it up with a shaver. And trust me, I've tried it, but it's going to take me forever. So a little tip here is to use that arthroscopic biter and actually take a nice punch out of there. So take a good, healthy punch. That'll actually give you a working edge. You then take the shaver and kind of shave from either of those ends. And the first time you do this, and maybe the first couple times, you're going to feel like you're destabilizing the joint. But you need to get rid of that area. It's going to cause pain. You bite it out, you shave it away, and then we use the kind of that RFA or ablation wand to go ahead and shrink the tissue. And again, on the right, what you see, a nice healthy fibula, and look, there's the syndesmotic ligament still intact there. This even sets you up to do your arthroscopic lateral ligament repair. Aside from soft tissue pathology, there's a fair amount of bony problems that exist and can also be addressed arthroscopically. So post-traumatic arthritis, as a primary indication of ankle arthroscopy, typically results in spurring at the anterior portion of the distal tibia. We can see the lipping here over the anterior tibia in front of the talus. And again, ankle distraction is used to gain access to the entirety of the spur and also to the rest of the joint. Here we find it best to use a larger burr to go after these spurs. Typically, we're using a 4-0 burr. You set it on continuous and you kind of sweep it across the front of the joint. And sequentially, you just remove this entire spur and then bring it through a range of motion at the end, making sure that there's no residual impingement to allow for your excision of the bone at the front of the joint. Loose bodies are also relatively common following fracture. I think they're more common following some of these avulsion fractures at the distal aspect of the fibula. Now, they can be chondral fragments, osteochondral fragments, but again, those avulsion fractures typically happen at CFL or even at the AITF. So these patients can complain of locking, catching in the joint, and really this is something that should be removed. This can cause a significant gouge in the cartilage, scratching, inflammation, pain, and damage to the chondral surface. So this video shows a pretty large loose body in the lateral aspect of the joint. We find it most helpful to use arthroscopic graspers to go after these. A shaver or even an arthroscopic biter or scissors can be used at first to loosen up these fragments. They may not be freely mobile the first time you get in there, but go down there, grab it with the grasper, and then we like to use a little log roll or gator roll type fashion to pull these things out. As we all know, osteochondral defects are one of the most common pathologies addressed in ankle arthroscopy. So first we examine the cartilage with probe, and once we identify the lesion, the loose cartilage is then removed with a curette or a shaver to identify the extent of the lesion and exposing the subchondral bone plate. So historically, studies have really shown that your treatment should rely on the size of the lesion as well as the age of the patient, but we really found success primarily treating most of these lesions with microfracture. Obviously, those that fail initial microfracture may need additional treatment. You may have to do some allograft cartilage shoulder replacement or joint replacement in severe cases. Again, using traditional microfracture, we can get most of these done. A technique that we utilize is most commonly described in knee literature. Instead of a microfracture, utilizing picks, as frequently described, penetrating a few holes in the subchondral plate, we actually expose the entirety of the lesion. I think that this allows for more ingrowth of fibrocartilage across the entire thing. And again, at first, go ahead and clean up the lesion with the shaver. We then remove the loose cartilage fragments with the curette, as you see on the bottom left. And then instead of going ahead and poking a couple of holes with the picks, we actually use a small 2-9 burr and just completely remove that superficial subchondral bone plate. Again, the idea here is that we're exposing the cancellous bone, allowing for this whole fibrocartilage layer to grow. So the lesion in this image is been appropriately contained, right? There's no loose pieces of cartilage. We then take that 2-9 burr and bring it across. And now we're controlling our treatment of these lesions. We're not kind of pounding picks into the underlying bone, causing further disruption to the talus. And also, I think it's a good point to say that, you know, maybe this is what's preventing our cysts from forming. We're not making these large holes into the talus for the synovial fluid to escape down into the cancellous bone. We've really had good results with this technique. So looking at the video, this is kind of standard how we approach these 2-9 burr, and we're using this to perform that abrasion arthroplasty, taking away that superficial portion of the bone plate, allowing the underlying cancellous bone to be exposed and new cartilage to grow in. So here we can see that end product of a well-contained lesion, really with exposure of that underlying cancellous bone. And as I mentioned before, we can push the boundaries on the size of the lesions that we're treating with this. You know, sometimes 1 centimeter, 2 centimeter lesions, even patients you think they're going to do terrible, see them in the OR and they look so bad, but they come in and they honestly have no pain. 5 days post-op, they're loving it. But we're kind of gathering preliminary data. Dr. Perez has been working pretty extensively on this. So we've seen excellent results and actually a significant decrease in reoperation, even in the larger lesions. So if you're interested in kind of learn a little bit more about this, maybe utilizing it in your practice, keep an eye out because we'll have those findings published here soon. But with that, I'll turn things over to Dr. Belis to talk a little bit more about arthroscopic ligament repair and some other pearls.
Okay, great. That was awesome, you guys. I appreciate it. So, all right. So this is great that we can share this knowledge with you guys, and I appreciate that you're all sticking with us. We're going to hit some clinical scenarios and cases at this point. We can't forget that when you do see that intra-articular pathology that was discussed, it frequently accompanies mechanical instability. And that's really, I think, why some of these articular defects happen to begin with. And there are some studies that show that even in acute ankle sprains, OCDs can be seen in 50 to up to 89% of the patients. And I think that's why when we see chronic ankle instability, we see such a high rate of intra-articular pathology. So go to the next slide. There we go. So in my algorithm for these conditions, basically, I really only use open ligament repair when it comes to specific conditions. Number one, if it's a revisional surgery that requires a little bit more involvement, visualization, and making sure we have to remove anything that's old hardware. If the lesion is too large, also if there's concomitant pathology like peroneal tendon issues, or if we need to do grafting of some sorts or some kind of augmentation, at least I used to do a lot of my augmentation open approach. Now, if you are inexperienced, there's no harm in doing a primary repair and then eventually going into an arthroscopic, a primary arthroscopic look at, and then do an open repair. But besides those indications, basically I do everything else arthroscopically. This procedure does get a lot of criticism, the brostrum versus the open brostrum versus a scope brostrum. And there's definitely studies that dispel this myth that these findings can be equal. That the torque and the strength is equal in an arthroscopic versus an open repair. So this is a slide of basically how we treat some arthroscopic treatments. 1 second, I'm having some AV issues here. There we go. So basically, when we do these debridements, we start off with a shaver and we just dissect out. I'm not sure why this is advancing. Okay, so we dissect out the lateral tissues. We resect the ATF attachments on the fibula, and we can do this with a full radius shaver, or we can do it with a radiofrequency ablation. Frequently, you use both of these, and that assists with this. And as Greg talked about earlier, taking down that AITF, and really what I like to do is dorsiflex the foot and see if it gets and see if the impingement is present. And if it is, then we for sure want to take this down and eradicate any potential impingement syndrome. There's nothing worse than doing a full repair and getting a patient post-op and they're stable, but they have a lot of clicking and impingement pain, and then you have to go back in again and take care of them. And that's not what we want to accomplish. So arthroscopic ligament repair can be accomplished with through the same portals and also sometimes with accessory portals. And basically the sequence is you're going to be drilling your holes for your anchor through the anterior lateral portal. You can use a pin or a cannula, and you want to be about 1 centimeter from the tip of the fibula. And in this image, you can see in the left image, we're using a cannula guide wire for the cannulated drill. And on the right, and when you get a little more experience, you can do this under direct visualization. You can certainly use C-arm to help guide you. And then you're going to be placing an anchor in the anterior aspect of the fibula. So here we are placing our anchor. We want to use, in this case, we're using 2 anchors spaced approximately 1 centimeter apart. We used a biocomposite anchor in this particular situation. However, you can use variations of this and other types of anchors. There's many different companies out there that provide anchors for this utilization. In this situation, we see one with an anchor with 4 sutures. It does provide a smaller footprint. It's a little bigger anchor, but it does provide the necessary sutures that we're looking for. And on an X-ray exam, you can see here that we have, we can see the drill holes for where we place that anchor to ensure proper placement. Okay, so the technique is such, once you have your anchors, you want to pass these into the anterior and distal aspect of the ATF ligaments. And these sutures are going to exit the portal. These sutures that are exiting the portal that you just placed are going to be rerouted back in through the portal and passed inferior or distal to the ATF ligament from an inside out approach. And you're going to be passing these percutaneously through the skin. And you can see on this picture on the right, bottom right, we have those little marks that we put there as our estimated exit point. And you can see we're passing the needle on this diagram in the middle where it may want to exit. And a lot of times we try to incorporate, those marks are a little bit proximal, they should be just a little bit distal. We want to incorporate a portion of the extensor retinaculum, which will help your subtalar joint instability as well. This is a really important part when you're passing these sutures because you want to prevent entrapping the capsule into your repair. And if you don't get these taut perfectly, you will have, they will lose their function as well. So you can see on the picture on the left, we've passed our suture. Our suture passer is pulling the suture, and you can see it on the picture on the right. You have that white suture, but it got caught on the capsule there, as demonstrated with that image on or that red arrow. And that's not what you want to have happen. And now, if this is a large portion of the capsule, you have to rethrow this. So don't be afraid to take this out and put it back in again. If it's a small portion of it, you can just basically snip it with a hand instrumentation and allow that suture to sit back down where it needs to sit in its trajectory towards the percutaneous hole that you created earlier. And on the picture on the right, you can see it's absent. So once you've passed the arms, in this picture on the right, you can see that the suture pass has been passed already, and there's four arms of the suture, 4 different specific arms. And there's the portal site there. You want to try to grab the retinaculum as we talked about, and then you're going to create a central hole in between there, a percutaneous hole, really small, just enough to get a probe in. And then you're going to take and repass them to that area there. So now we've incorporated all the sutures into that one hole where we can then tie them down and fix them and advance the distal portion of the ATF back onto the fibula. You want to do that with your foot in dorsiflexed and pronated positioning. So after these, what do we do for these post-op protocols? Well, these are pretty aggressive procedures as far as stability-wise, and we get them going pretty quickly, excuse me. First, during surgery, we use a soft bandage with a cam walker or splint. At the 5 to 7 day mark, we're weight-bearing these patients in a cam walker, especially if there's no block. We're immediately weight-bearing these patients if there's no block, and we're non-weight-bearing them if there's a block, because the block obviously makes the foot go numb and you can't walk on it. At the 5 to 7 day mark, we check on the incisions. We start range of motion 3 times a day. We do a weight bearing as tolerated in a cam walker. We try to minimize inversion at that time period. At the 2 week mark, we're taking out sutures and we're doing continued range of motions. At the 4 week, we're advancing them to a lace up brace and we're starting PT. So we can be really aggressive with these patients pretty quickly. At the 8 week mark, we're doing compression socks for normal gait, lace bracing for physical therapy, and they can start running and cutting techniques. And at the 12 to 14 week, they're beginning heavy duty sporting activities. So that's pretty good. Can we do better? Well, I think, we're all familiar with the augmented suture repair in an open procedure. Can we incorporate that into this arthroscopic procedure to get the best of both worlds? Well, we know that using some kind of augmented repair with additional suture and additional anchors in each side of the joint will help double almost strength of the normal ATF ligament as well as the repaired anchor technique. So let's try to incorporate that. And this, you can see in this case, we've tried to incorporate that. We see the 4 strands that we've passed through our inferior retinaculum. You can see the marks that we aim for here. It's really important to note that you have to draw out your marks preoperatively. This is critical because once you insufflate this joint, you won't be able to see much of the landmarks anymore. So draw everything out beforehand. I know it takes an extra second or so, but that really helps, especially if you're doing these things arthroscopically. Here, we've placed a suture tape through into the anterior aspect of the fibula. We're exiting our portal site. On our next picture, this is just the orientation that we'll have, and you can see we're kind of pulling on these sutures in the direction that they'll be going. And on this picture, we're shuttling. We've already tied off our distal sutures at the retinacular area, and they're buried already. And in this picture, you can also see we're passing the suture tape through an ancillary portal that was created at the talar neck. And in this case, we've also identified this spot with our guide wire. And the guide wire is kind of oriented similar in a way where we would put our anchor for the talus. And you can see that's where passing this. And there's that suture pass. So now we have 1, 2, 3, 4 little puncture spots. And here's the anchored ligament. So through this lateral accessory portal, once we place our guide wire, we can then place our anchor and tie down our suture augmentation to the talar neck at the distal insertion point of the ATF ligament under normal physiological tension. And that's the end result. So portal closure, just a quick little side note, portal closures, you can use either sutures or steri-strips. There's a good study that indicates that either one do fine. And again, most of these things you want to be doing, you want to do them quickly because this study did show that a shorter tourniquet time had less infection rates. So getting proficient at these is really important. Can we push the boundaries with these arthroscopic ligament repairs? Well, yes, we can. So in this case, we have a patient with a deltoid ligament insufficiency tear. Really, that's all they had. It was from a specific injury. They were having some trouble healing. So we incorporated this similar technique into our repair through the medial portal. And in this picture, you can see on the left, we have our anchor guide, or our guide for the drill, entering the medial portal. And in this picture, you can see what was drawn there is that little blue circle. That's the navicular where the PT tendon inserts. You can see that those two little holes we're projecting to pass our sutures percutaneously. And you really want to aim for your deltoid insertion, especially near the navicular area and that the dorsal medial spring ligament area type positioning. And you want to be careful for your saphenous nerve and your vessels there. So on the second picture, we see our drill starting up. We place our anchor in, and in this case, we use an all suture anchor because the cortex is very hard here and it held very nicely. And on the bottom right, you can see those sutures with the exiting that portal site. And similarly, we use a suture passer on this picture to pass through to the marks that we created in the skin. You want to pass each arm separately, and you want these sutures to glide so that way you can really tie down that knot and bury that knot deeply. You want to avoid those structures, stay deep, and you want to really try to do this under direct visualization through the contralateral arthroscope. All right, and then that's your final puncturing through. And then we similarly create a central portal site or an accessory incision to pass these sutures and tie them down. Here's our tying process, and you can see the picture on the bottom right is our finished product. Very sturdy here as well. And in this case, we also did a lateral repair, and on the x-rays, you can see where our medial anchor site is, as well as the lateral anchor site, and you can see good stability of the joint. You can also use these arthroscopic tricks and techniques for ankle fusions. And obviously, this is just an example of what an extensile incision would be for an open ankle fusion. So obviously, these have their own risks. They have their own problems. And so if we can do this better, quicker, lesser invasive, and preserve vascularity, this is a great indication for arthroscopic repair. Here's an example of the incision on this page. You can see all the way on the right with the big scar and the big problems. And you can barely see the incisions on this patient who's had an ankle fusion as well. So you can see that really preserves the soft tissue envelope, and we accomplished really strong early fusion techniques with this. Speaking of arthroscopic early fusion, there's a lot of studies that show really good indications for doing this. and quick healing times. Usually we try to reserve this for minimal deformity. Higher risk patients, these might be a perfect indication to preserve their vascularity. And you can see here the significant studies that indicate a quicker healing time. Arthroscopic fusions on average heal about 9 weeks, according to literature. Opens are about 14 weeks. So, certainly it helps the patients out, it helps us out, and patients do a little bit better this way. Here's just an example of us doing a debridement of the technique, and you really want to expose that subchondral bone plate. A couple tricks with this is that you have to make sure that getting the front of the joint is easy, getting the back is the hard part. So don't be afraid if you have to make a posterior portal to help with this, as well as resecting really trying to get to that back section of the joint is really important here. The other thing is when you fuse these joints, you have to posteriorly displace the talus on the ankle just to get that centered. So you really can't miss that posterior aspect of the joint. Here's an example of joint prep. You can see really good, almost medullary bone where you've penetrated through that subchondral plate. And that's really what you want to see here. With these, you usually have to be prepared to put an injection of some kind of graft material in here just to fill the nooks and crannies, and that helps out quite a bit. Here's another example of, you can see how much we beef up these and prepare them. It almost looks like medullary bone all over the place, and that's a great finding right there. You can also plan out your hardware placement with this. So when you place your guide wires for your screws, you can see that accordingly and get that positioning perfect. Here's another patient who had a pretty bad work injury and ended up going to an arthroscopic ankle fusion. You can see how well she fused in this situation. And this was a very high risk patient. She had really poor bone quality, and so these patients do very well. So I wanted to leave a couple minutes for some questions. I guess, Adam, do you want to start with questions, or do you want me to ask my fellows the questions that I have made?
Well, we did have a couple questions from the chat box. One was if you can comment on any nerve problems with the distraction or neuropraxia with the distraction, and I guess the incidence of it, and then also if you do have that, what are your typical treatments for that? Okay.
Do you want me to give one of you guys the opportunity to answer this, or do you want me to handle this?
I'll talk about my experience with it, and then you can kind of piggyback on that. I think that it does exist. It's out there. But honestly, over the past at least year, this is the first year I've used ankle distraction, I did not see any neuropraxia resulting from our distraction. I think it depends how long you're doing the distraction for. I wouldn't keep the ankle in distraction for more than an hour. I probably wouldn't keep it in distraction for more than 40 minutes. But I think that if you look at the opposite way, actually kind of studied the arthroscopic versus open lateral ligament repairs, and the neuropraxia is similar in both of them. So that open incision also leads to a lot of irritation on the nerves, but from the distraction alone, not an increased incidence of nerve injury at all. But again, you can have an increase in nerve problems from just the block by itself, as well as even using the tourniquet. So I think time of distraction is key there, and also not leaving the ankle in distraction, but doing what you need to do, taking it out of distraction, and going from there.
We got Danny. Hold on, Danny's got a quick comment.
Yeah, absolutely.
To reiterate that point, so far, in my short time here, I haven't seen any complaints of neuropraxia, and if it's locally around like the SPN nerve, it's hard to say, even if it was a joint distraction that was the cause of it, or maybe there was just an injury when accessing the joint. That's a possibility. But thus far, I haven't seen really any issues. And again, back to that slide that I talked about, Van Eyck published literature stating that, it could be safely about 135 newtons of force or 30 pounds of force can be safely applied for up to an hour. I mean, I understand, we can't really exactly quantify that, but,
Okay. So my answer, I think there's multi-part question. Number one is, I think the nerve blocks do way more injury than when we give them credit for. So I think having a popliteal nerve block, and actually Greg did a is it a study that you did on that, or like a little on the popliteal?
It's just like a lecture.
Well, like a little lecture on popliteal injury from nerve blocks, and many of them are transient, so you can get them frequently, so it can happen, but they're transient and they usually go away within 3 to 6 months. Because we've seen that more commonly with blocks, not necessarily with arthroscopy, because we do a lot of cases that are not arthroscopy that have blocks, and they have similar issues, similar rates of neuropraxia or nerve temporary nerve damage from the block. So I really think that that's a big source of problems. But to preempt that, one of our treatments and one of our standard protocols is to give people gabapentin or Lyrica, either pre and or post-operatively for a certain time period to help with that. Also, what I found with nerve damage is early ambulation helps. The more you mobilize these patients, they just have the nerves go angry, they go crazy, they go haywire. So you got to get these patients moving, which is why we focus on making our stability as strong as possible, getting these patients moving as quick as possible so we can accomplish those goals.
How soon are you walking your ligament repairs when you do it arthroscopically?
I mean, day one.
I mean,
have a block.
Without a block, day one. They can put weight on it with a boot.
Okay. Couple other questions. Dr. Peterson was asking about the need to distract if you use a smaller scope size, such as like a Nano Scope. Do you have any experience with that?
I don't do a lot of Nano Scope. I think number one, it's access to it is difficult for me in my facilities that I work at. Number two is I think that most of the stuff that I'm doing is, if you're going to go in with a nanoscope, you're only looking at the joint. Meaning, if the joint can't distract more than that, the only thing that that's being used for is diagnostics. Because if you can get an instrument into the joint and do debridement, then you can get a scope into the joint, a standard scope. So I think that I don't have a lot of experience with that. Certainly, if I just wanted to take a little quick look at it, and that would be an option. And I'm sure there's a lot of people doing that in their offices, and that would be fine. For me, that's not my algorithm for treatment, is not to just do a scope for the sake of looking at it. When I do diagnostics, it's usually a combination of clinical, and I try to emphasize that with these guys, is we do diagnostic joint injections with local, or maybe we do arthrograms. We do a ton of arthrograms, and that gives us a lot of more information. And frankly, it tells the patient how they might feel like once we've corrected their problem intra-articularly.
I think you can get to some stuff that you need with small instrumentation, like a 2.9 scope, maybe a 2.9 shaver. You can get some OCDs at the front of the joint. You can even get to a portion of the syndesmosis with the shaver. But a lot of the other stuff that's out there that's made, I mean, not all the instrumentation comes that small. For example, one of those, ablation wands, they only come in a 4.0. So the little one is it's like a little point. It's almost like a bogey. It's not going to do what you need it to do. So I think that it goes on other points to say that you can do some with small instrumentation and not needing the distraction. But I think that distraction is going to just expand your indications and allowing you to use more things, use bigger equipment, and really gain access to the posterior portion of the joint.
So I'm going to openly admit I don't use ankle distraction, but in viewing your lecture, it really shows that I'm probably missing a lot deep in that joint. So if you have surgeons that are not experienced with distraction, obviously there's a lot of tricks to it, and a lot to learn about it. One, can you comment on what's the best place to get trained? Obviously for those of us that are out in practice, is it through webinar? Well, not webinar, but like a workshop? Are there different workshops out there specific to that? And then obviously if you're a fellow, you can go and just train with you. But
Yeah.
where did you learn to use distraction, and when did you start using distraction, and what would be your advice for those of us that aren't using it but would like to start incorporating that in?
That's a great question. I listen, there's two components to this. Number one is your inherent hand-eye ability. So all those, I guess, Gen X's and people who know how to do things with the video, handheld video games and things like that. I think there's a certain degree of people who are just good at their hand-eye and visualizing it. But really, it just takes time and experience. And this is one of those things where there is a little bit of a steeper curve to master this technique and master even the more advanced arthroscopic ligament techniques. For me, it didn't happen like all of a sudden I started doing this. And in my training, I had exposure to arthroscopy, but it wasn't phenomenal. So you pick up things that way, but more importantly, it takes doing the cases, and it takes going to arthroscopy seminars and hands-on cadaver labs. I'm telling you, that's what you have to do. You have to have that experience. And you have to train with somebody who knows what they're doing, because there's a lot of guys who say they do arthroscopy, but they really don't do it to the robust nature that is potentially out there. Now, one of the things that I was saying earlier about doing an arthroscopic look in the joint and then converting it to an open, that will give you the training at step approach, and that's safe and it's standard of care, and you're not experimenting on a patient. It's proper technique to especially for all your lateral ankle ligaments. Just look inside the joint with a camera. It takes 20 minutes. You make your tiny portals that are very low risk. You look in the joint, you practice your distraction, and you kind of start there. Then from there, if you're not comfortable doing anything more than that, then you can break down the joint or open it up, so to speak, and then do your open repair accordingly. There's still good data that shows that's a good technique. So you start with that. But you have to get your hands dirty, and you have to have those cadaver labs. And for me, I would be a surgeon training other docs at a cadaver lab, and they didn't even know the instruments. So don't go into these cadaver labs not knowing anything. I mean, you have to do your homework. You have to know what a scope is, what the angle is. You have to know which direction you're looking. That's the hardest part. Once you master that, then you can say, okay, I know if I want to look left, I have to turn my camera angle. If I want to look right, Greg pointed out earlier, keeping your horizon, always keep that, never getting lost in the joint. So those are really good pearls, but you have to kind of do it over and over and have methods. Here's step one, here's step two, here's step three, and then you can kind of really excel accordingly.
So I have a couple other questions. Going back to the opening where you guys were talking about your OCD treatment, can you just talk us through your algorithm for that? So you do a scope, you do your debridement, and let's say the patient comes back and they're still having quite a bit of pain there. Are you rescoping them? Are you doing any sort of advanced biologics? Are you using cadaver allograft? How are you repairing those OCDs? And what are your stepwise approach? Obviously, working your way towards an open osteotomy to get a better visualization. But what's your algorithm with your scope for that?
Yeah, that's a great question. Again, I think that, as I get more mature in my practice, and I'm seeing that just following the literature is not always the appropriate thing to do. So if there's a lesion that's 2.5 centimeters, it may not be the right choice to put an oats in there, or to put a larger graft in there, or an allograft. Now, for me, my algorithm is, number one, if they have an OCD, there is a ligamentous issue, usually. I would say majority of the time. So we have to, number one, assess your biomechanics of your joint. Number two is MRIs will tell us what's going on. Sometimes the pain is not necessarily the articular loss. It could be an impingement. It could be a spur. It could be a cyst underneath the subchondral bone plate. So if it's just an OCD from ankle instability and not many of these other weird things, then my typical rule of thumb is get in there, scope it out, and obviously fix the ligament, scope it out, and then do that arthroplasty debridement that we talked about. And then once, even if it's a larger size. Now, if it's the entire joint, obviously they need a joint fusion or joint replacement. But for those larger lesions, I would still start with that. Then we get them moving right away. Too many times you do an OCD, you do a lateral ligament, you immobilize the lateral ligament for too long, and then there's adhesions and scar tissue. And when I have to go back in to rescope them, there's scar bands and plica and all these other bad things that happen in the joint. So so getting them moving is the key, and that actually improves the outcomes, in my opinion. So step one is that abrasion arthroplasty for OCDs. Step two, if they fail that, or if they're workman's comp, because they always fail that, is to go back in again, do a debridement, and maybe we'll do articular transplant. And there's various companies out there that have those options. Or even just doing a rescope, and sometimes I'll even just do a post-operative injection of the joint to break up adhesions, and that usually helps. PT helps. Now, if that still doesn't work, then yeah, my next step is to do maybe the Oates procedure or a transplant. But honestly, if it's so bad where we need to take down the medial malleolus, we have to really have a bigger question about if that's the right procedure for that patient versus some kind of reconstruction or an arthroplasty or something of that nature.
So on the topic of scopes and foot and ankle, what other places are you utilizing scopes? Are you scoping subtalar joint, and what's your indications for that? Are you doing any tendons? Are you doing the first MPJ? So if you can comment on that. And then the last part to this question is, on your ankle fractures, do you ever, or pilon fractures, do you ever do dry scoping?
So yeah, posterior subtalar joint and posterior ankle is something I do a decent amount of. I think not as many as the anterior scopes, but when needed, we do that. And I think that's a tricky scope to do for most people. But I think that's very fulfilling for people, and it helps a lot of their problems out. When you said you do tendoscopy, I mean, I think the most common tendonoscopy I do is the FHL tendon, as of course is posterior to the ankle and the subtalar joint, and you're removing adhesions around there. I remember specifically I had a young lady, she was a teenager, and she was a sports player. I think I want to say ballerina, but it wasn't that. It was some other sports. But she basically had adhesions and clicking of her FHL tendon as a course through the canal there. And we did a tendoscopy / posterior arthroscopy, and her symptoms were resolved. So I think those are the more common things. I don't do it for first MPJ. I think if your first MPJ is arthritic, it's a biomechanical need for correction and not necessarily just a quote cleanup or cartilage resection. It usually needs it's usually hallux limitus or some other damage, and I find that those just don't do well. And then in regards to because I don't incorporate a lot of the microscope options, I don't do a lot of diagnostics accordingly. And I find that tendoscopies are just very challenging, and I've not mastered them. And I think I usually get sufficient treatment through open care for that. So I have not done a lot of those.
Ankle fractures. I think there's a fair amount of ankle fractures that get scoped. Hardware removals, fair amount of hardware removals get scoped. Again, post-traumatic arthritis is going to set in. Taking out the hardware, a little extra incision doesn't hurt to at least scour the joint and take a look. I think the question then becomes, when you're scoping ankle fractures, is it more for fracture reduction, or is it more to evaluate the joint to see if there's an OCD? Now, again, if there's an OCD in a acute ankle fracture, are you fixing it, Dr. Perler, or are you letting it go?
OCD with ankle fracture. So I'll debride it, obviously, if there's anything loose. And then in my hands, I've been doing microfracture, but I think it's really interesting what you guys were presenting and how you approach that. But usually just basically doing reconnaissance on it. If it's a large enough lesion, then I'll stage kind of a more open approach to patch it, because obviously I wouldn't necessarily have any cartilage alternatives or options available when I'm fixing the ankle fracture. If we're doing like a cartilage implant or Cartiva or something like, not Cartiva, sorry, one of the cartilage allografts, I wouldn't necessarily have that available on that first pass. But yeah, I think that we miss a lot of lesions with ankle fractures, because if you think, especially any dislocated ankle fracture, I think warrants doing a scope on.
Yeah, first of all, I try to scope pediatric ankle fractures when they come in. So because I think you need to really get those things perfect, you need to see them, and you need to make sure there's no loose fragments of bone, because if those kids are having surgery, you want them to have a one and done procedure. Number two is I think when I do my ankle fractures open, as opposed to lesser invasively, I like to almost do an arthrotomy of that fibula and look directly at the joint. Number one, that's the fracture pattern, especially in SER. It comes up and you have to explore the interlateral aspect of the joint, make sure there's no impingement of the soft tissues like that AITF we talked about, or maybe a loose fragment of bone. But by doing that, you don't have to scope your joint, because now you've just extended your joint, your incision to the arthrotomy portion, and you can actually look at the joint and treat the damaged cartilage accordingly.
Excellent. At this point, we can open it up. If anybody has questions, whether you do it through the chat or you can just unmute yourself, feel free to ask.
I think that's another good point, though. I mean, when you're talking about how do you learn to do these things, I mean, it's something that you have to get your hands on. You're not just going to be able to, watch videos and read. You should do all that background stuff, but you have to get your hands on it. So if you are removing ankle fracture hardware, I mean, that's a case that you could scope. If you are doing an ankle fracture and you're concerned if they have OCD or even ankle pain. I mean, the hemarthrosis alone, by putting the scope in the ankle fracture, I mean, there's good literature that supports just getting rid of that hemarthrosis and irrigating the joint is beneficial for the patient. So other things you can kind of incorporate in your practice and really get to use, and it gets your hands a little bit more wet with this.
That's an excellent point. Anybody from the audience have questions? You can unmute yourself and ask away, or you can send a question through the chat.
Hey everybody, question for Dr. Belis and your team. I have a patient that she's been diagnosed with what's called a benign hypermobility syndrome, kind of like a marfanoid of sorts, and she has just severe ankle instability, both laterally, primarily, and medially. So she has about a 6.8 by 7 meter defect approximately. So I'm not as near as they experienced arthroscopy as your team. So I was definitely planning on scoping her and opening her, but for a lesion about that size, would you do the arthroscopic debridement and use an autograft, or just you find that the microfracture is sufficient?
How big was the lesion? Was it 6 to 8 millimeters?
Yeah, approximately. I'll get the exact. It's roughly about like 6 by 7 approximately.
Yeah.
The dimensions. Let me pull up her MRI.
Listen, I think this microfracture technique is an interesting topic, because I find myself puncturing a big hole in the talus and just regretting it or just hating it.
Yes.
And so for me, this modification of this technique that we did incorporate, I think it just scrapes up the bone enough that it stimulates cartilage. You're not burning any bridges, and you're removing the loose flap of cartilage that usually causes pain and catching. So in your particular case, however, I would do that as a first start, because according to my algorithm, remember we talked about that's first step. Second step is deal with the hypermobility syndrome, because if that joint is moving out of the joint space, it's going to continue to damage and bang around. So in those cases, especially with Marfan's and ligamentous laxity, and you have to do some kind of supplemental augmentation with a non-stretchable type tissue, or even a tendon graft in some cases. So I would definitely do the augmentation right off the bat with that person, and make sure you get that ankle stable first. And I think that you'll see that the joint damage will kind of resolve itself. Now, if that fails, you tell them, hey, listen, the only other option would be we put cartilage graft or some other type of revision in there. But usually when you get back into these patients again for a second time, it's not that the cartilage, the bone is exposed anymore. It's actually, you'll see it filled in with some fibrocartilage. What happens is that there's adhesions, and those adhesions are the ones that just need a second cleanup, and most likely because people immobilize them too much. So that's where that quick mobilization is so critical with any OCD or intra-articular damage. Hope that helps.
Yeah, no, those are great points. Anybody else have any questions? You have an arthroscopy expert to ask.
Well, I know it's getting late, but I mean, I'm happy to. I think you guys have my my email or our phone number and the email. Feel free to email us. I think if there's any other questions, I'm happy to share my information. Hopefully, guys, you picked up a little bit about this tonight, and I know I had fun. And listen, I just want to say one last thing before we finish up. This is for the fellows. This is for our future of our profession. Sharing information, teaching these guys, being a mentor. You guys every one of us has their specialty. You guys should all be your mentors and try to help elevate the entire profession. And this is just my little part to try to help. And I want to say I'm very proud of my current fellow, my past fellow, and some of the people we've trained in the past. And I want to say thank you to Adam for being part of this. And also thank you to all the other fellowship directors that are doing their job, as well as residency directors. This is what it's about, is kind of elevating our profession.
Thank you, Dr. Belis.
And a special thanks to Karen.
Dr. Foote and Dr. Perez.
Oh, hey, Elvis.
Hey, guys.
Also wanted to thank Karen and Alessa from FPMA. They're the glue that holds us all together. So we really appreciate their efforts, and not just on FPMA, but FPMA, FPMS, and the Fellowship Society. We're really lucky to have them as part of our state. So thank you to them. And if anybody has questions, you can always email them to FPMA, and they can channel it through us. There will be other seminars coming up, so you can always open questions at any point. So we look forward to seeing everybody next month in November for Total Ankle. That's going to be really exciting, and help us spread the word about this event and these webinars. And thanks everybody for their support.
Thank you to our sponsors as well. Thank you, Jeff, as well. All right.
Okay. So
have a good night, everybody. Thank you so much.
Conclude. Thank you, guys.
Okay.
Thank you.